let me thank all the organizing committee for inviting me for this, and I'll share my my slides. This is about a case. I worked in a hospital where there is a very nice oncologist, and he's very active and has a lot of medical knowledge. And we worked together and put all the guidelines for the anticoagulation, prevention of DVT in the high-risk patient. So I worked with this oncologist, and we did a lot of scientific work, and also started the protocol for evaluation of chemotherapy-induced cardiomyopathy and checkpoint inhibitors. And I told him I can do peripheral intervention if you have a case for complication of oncology or superior vena cava syndrome. I'm ready to do the intervention, or occluded central catheter. But he never referred any case to me over 2 years. He kept referring that to the interventional radiologist. So I decided this oncologist doesn't like me, and just will have respect for each other. Just what happened after 2 years working together, he actually he let his secretary call me and asked me to see this patient. This patient is 56-year-old male non-smoker with suffering of head and neck cancer, and he received multiple radiation therapy to the head and neck and started on chemotherapy a few months ago. 2 months ago, he had a TIA and was treated conservatively. Carotid Doppler at that time showed no significant lesion in the carotid in the neck. During this current hospitalization of chemotherapy, he developed another TIA with dysphagia. So they did CT angio of the head and neck vessel, and consultation requested. So when the secretary called me, I did not pay that attention because I thought probably it's a simple thing, wants my opinion. And I asked my fellow to see that consult. So the fellow went and reviewed the chart, and he called me and sent me on WhatsApp. This is the picture, and he has stenosis in his left internal carotid artery up high. If you see that here, I hope that you can see that. Can you see it? Yeah,
we can see that.
Okay, good. So this is the picture, and it's clear on the left, and there is mild disease on the right, but this is. So I thought, oh, this is a nice case. So let's put him for the cath lab for the next morning. So we'll do angiogram and do intervention since he has recurrent TIA. So since the fellow did the consult, I asked him to start the case, and I asked the fellow to start this angiogram, and he did this angiogram, and he said you use simple Jatker right, and did the angiogram of this right subclavian. And I was watching him from the control room, and I saw that picture. When I saw that picture, I said, because I don't see the carotid here, so this is a separate origin of the right subclavian. So we may face some difficulty. So my fellow continued to do the angiogram. You see his Jatker right, and he wasn't able to engage any of the carotid. Just he did the non-selective injection, and you see this is the left carotid originating here and the right carotid originating here. So at that time, I had to put my lead on and enter the cath lab, and I used this Siemens catheter, and with my humble experience, I was able to engage now the right common carotid selectively, and did angiogram of the right carotid. You see there is no significant stenosis. There is 50% stenosis up high, and I went and do this intracranial angiogram, and you see this is on the AP view. This is on the AP view. You see this is mild stenosis here, but there is the filling of the anterior cerebral and middle cerebral, and you see there's filling through the collateral to the other side, that we can see the anterior cerebral and the middle cerebral on the left side. That means disease on the left side is significant. If you want to see the lateral view, this is the lateral view, and you see this is the disease and good filling. So we have to do the selective angiogram of the left carotid. This is a fixed picture of the right carotid. You don't need to see that. So I tried to engage, and I couldn't be able to engage the left carotid. So I said, I need to review that CT. So I asked the technician to open the computer and enter into the radiology viewer and do the CT, review the CT picture. And this is what I did. That my fellow did not send me that. And this is what I saw. If you see that, there is this separate origin of the left carotid, separate origin of the right subclavian, separate origin of the right carotid, separate origin of the right subclavian. So with that, and this is a right-sided aortic arch. So now we know that this is the left carotid artery is originating almost from the ascending aorta. So I had to do a lot of maneuver. You see, this is the 3D reconstruction, and you see this is the left carotid originating from the ascending aorta. This is the right carotid originating separately. This is the right subclavian originating separately, and this is the left subclavian originating separately, and there is a pouch. And if you review that, this is called the diverticulum of Commerell. That's the remnant of the ductus arteriosus, but this is a right-sided aortic arch. So I was able to engage with a lot of maneuver and then do the angiogram. And this is the angiogram of the left carotid. I was able to do selective with a lot of maneuver. And this is the picture for the intracranial view. You see this severe stenosis. You see that we can see the middle cerebral artery, but the anterior cerebral artery, due to severe ischemia, is not filling. I hope that you can see that clearly. So if you don't see that, I have a fixed picture. This is the fixed picture, and this is the severe stenosis of the left internal carotid artery here, and this is filling of the middle cerebral artery and no filling of the anterior cerebral artery. This is lateral view, and this is the severe stenosis. So and finally, I did selective angiogram of the left subclavian, and you see this is the pouch dilation of the diverticulum that I mentioned at the previous discussion. So this is again. So I thought that this is, I need to flip-flap and do the workup that Cristiano Ronaldo did when he scored that goal, that put his back and flipped his foot to score the goal. But this is my picture when I tried to do this maneuver. This is my picture when I was in preparatory school. This is the best I could do. But this is the way that I have to enter down, reach the ascending aorta, flip the catheter up, and engage the left common carotid artery and go up. This is the fixed picture. And with that, I was able to put my guiding catheter up high in the neck, and then do the crossing. I hope you see this wire crossing. And after that, do the balloon dilation here. And this is stenting. I hope that you can see that this is stenting and the balloon inflated of the stent. So with that, this is the angiogram after I input the stent. I hope that you can see that there is no residual stenosis. And now we got filling of the anterior cerebral artery. So we release the stenosis and got good flow to the anterior cerebral artery, and the middle cerebral artery is filling. This is, let me show that in more detail in the digital subtraction. And this is the view. There is no residual stenosis. And this is the filling of the anterior cerebral artery on the left side. If you need to see lateral view, that's a lateral view. This is the area of stenosis. There is no residual stenosis. And we got thing. So I think it wasn't like Cristiano Ronaldo, because remember Cristiano Ronaldo, when he did that goal, he was coaxial with the goal. But this is like the way that Ibrahimovic did his goal. He wasn't coaxial with the goal, but he flipped his leg and scored that goal. So this is the way that I scored that. And I was successful to do this case. So just to continue with the history, the patient did well and was discharged. And another 6 months later, he was admitted with another TIA on the other side. So at that time, that oncologist, who doesn't like me, referred that case to his preferred interventional radiologist. And the interventional radiologist worked for 3 hours trying to engage those carotid, and he wasn't able to engage neither the left nor the right carotid, just he was able to engage the subclavians only, the right and left subclavian, after 3 hours. So stroke intervention is should be done by the cardiologist, because they can do that quickly, and the cardiologist may be closer than they appear. And if you have any stroke, you should call a cardiologist. So this is my presentation. I have few slides to review the embryology and pathogenesis. Either you give me a time, or I'm done with my presentation. We can do that later. So any question?
I think that you've given us a lovely presentation. I don't know that we need some further talks, further presentation from you. I thought it was very clear what you've done. I thought your title was lovely. What about the panel? Does the panel have any questions?
Which catheter did you use to finally access it?
Okay. Well, just shaping my catheter, I used the Judkin right first, and just curved it with my hand first, and then curved it more at the aortic valve, and pull it back. I was able to engage this aberrant left carotid, and put my wire. And after I advanced my wire, engage the catheter inside the vessel, and switch to a stiffer wire, and get this multi-purpose catheter to pass on, and advances slowly, keeping the loop that I showed you until I entered the neck.
From the location of the origin, it looks like a left coronary bypass gas seeker would fit right in.
Left coronary bypass. Anyway, thank for me. But now I do most of the bypass graft angiogram from the radial, so I have a different catheter. I almost forgot this left coronary bypass graft, but thanks for mentioning that.
Well, thank you very much.